Okay, welcome back. In this video, we will continue our video series on anatomy and physiology. And this chapter will focus on the urinary system, filtration, and fluid balance. A quick introduction to the system. The urinary system acts as a purification plant by cleaning the blood of waste materials. Now, the liver does some purification, but the urinary system controls electrolyte and fluid balances for your body. The kidneys will filter blood, then reabsorb and secrete ions, and eventually will produce urine. Now, without this important function, you would die within a few days. See, learning outcomes for this chapter. Present an overview of the organs and the functions of the urinary system. Describe the external and internal anatomy and physiology of the kidneys. Discuss the microscopic anatomy of the kidney and the importance of the renal blood flow. Describe the process of urine formation. Trace the pathway of tubular reabsorption or secretion of electrolytes and other chemicals. List and discuss the importance of hormones for proper kidney function. Describe the anatomy and physiology of the bladder and urine removal from the body. And lastly, discuss several common disorders of the urinary system. Alright, we'll start with a system overview. Urinary system consists of two kidneys. These are bean-shaped organs located in the superior dorsal abdominal cavity that filter blood and will make urine. And also they have accessory structures. The ureter is a tube that carries urine from each kidney to a single urinary bladder, which is located in the inferior ventral pelvic cavity. A urinary bladder is essentially an expendable sac that holds urine. The urethra is a tube that transports urine from the bladder to the outside of the body. And the job of the urinary system is to make urine, thereby controlling the body's fluid and electrolyte balance and eliminating waste products. To make urine, there are three processes that are necessary. You have filtration, as a reference to filtering the blood. And what passes through the filter that we'll talk about a little bit later on is called filtrate. Then you have reabsorption, substances that stay in the body after being removed from the urine. And lastly, you have secretion, substances that are moved from the bloodstream and then leave the body in the urine. Here's a general overview of the structures in the urinary system. You have the two bean-shaped kidneys here, each one with a ureter that comes out here and then here. They both lead to the bladder. And from there, you have the urethra, and you will urinate out of the body. Alright, we'll start with the external anatomy of the kidney. Now, the kidney is covered by a fibrous layer of connective tissue called the renal capsule. Now, it's this capsule that helps the kidney keep its shape. Now, the indention that gives the kidney, or helps give the kidney its shape, is called the renal hilum. Now, the hilum is not a term that's specific for the urinary system. It's a reference to any indented area where you have major vessels or lymphatics or nerves entering a structure. So you'll see the hilum referenced with lungs and kidneys and lymph nodes and spleen and so on. Alright, at the renal hilum, you'll have renal arteries bring blood to the kidneys to be filtered. Renal veins will take the filtered blood away from the kidney. The ureter is also attached here at the hilum. That will transport the urine that's been collected onto the bladder. Right, now move on to the internal anatomy of the kidney. The kidney can be divided into three individual layers. First one is the renal cortex. The cortex is the outer layer. Cortex is always a reference to the outermost layer of a structure. This will look grainy in appearance and has very little obvious structure to the naked eye. But this is where the blood filtration occurs in the cortex. Going more internally, the middle layer is the renal medulla. And here you'll have a number of triangle-shaped structures called the renal pyramids. And it's also composed of the collecting tubules for the urine that is formed in the kidney. The renal pyramids that are adjacent to each other are separated by projections of the cortex called the renal columns. So even though they dip into the renal medulla, they are still projections of the renal cortex. They are still cortical tissue. And the innermost layer is the renal pelvis. This is a funnel-shaped structure that can be divided into two or three large collecting cups called major calyces. Now, calyx is singular. Calyces is a plural form of that word. And each major calyx is divided into several minor calyces, forming a cup-shaped area around the tips of the renal pyramids. Now, the blood is filtered by millions of tiny filters in the cortex, and then that filtrate that's collected will flow through tiny tubules in the medulla and collects into the renal pelvis. The renal pelvis is actually the most superior end of the ureter. So the pelvis will empty into the ureter, where urine is carried on from there to the bladder. Alright, so here's an illustration of both the external and internal anatomy of the kidney. Of course, the capsule here, the outermost wrapping around the connective tissue. The hilum, the indented area here, where you have major vessels enter the structure, and in this case you also have the ureter, which is here. This will lead on to the bladder. Of course, the renal artery, renal vein. You have the cortex, which is the outermost part. The middle part is the renal medulla. And the innermost part would be the renal pelvis. These extensions of the renal cortex dip down to the medulla, form these renal pyramids here. So that's a pyramid, that's a pyramid, that's a pyramid, that's one, and so on. Okay, at the tip of each of these renal pyramids is a minor calyx. Those minor calyces merge to form a major calyx. So that'd be one here, that'd be one here, that'd be one here. All that urine is collected and then dumped into this funnel-shaped section here, the renal pelvis. So whatever is collected here will get passed on into the ureter and then onto the bladder. Alright, blood vessels. Now, having a good blood supply to the kidneys is essential in order for the kidneys to work properly. And there's a large network of blood vessels that are found throughout the kidney tissue. Now, for each kidney, there's a single renal artery that will enter each kidney at the hilum, and it will branch into 5 segmental arteries. These segmental arteries will further branch into lobar arteries, into the renal sinus. These lobar arteries will branch into interlobar arteries, which will pass through the renal columns. The arcuate arteries originate from the interlobar arteries and actually arch around their pyramids in the renal medulla. The arcuate arteries will give rise to the cortical radiate arteries, which give rise to the afferent arterioles. It's these afferent arterioles that will lead to the main filtering unit of a kidney, called the glomerulus. The efferent arterioles will leave the glomerulus. So afferent and efferent are very easy to get confused. Anything that's afferent is arriving at a structure. Anything that's efferent is exiting a structure. And those are terms that are general in anatomy. They aren't particular for the kidneys at all. And after the blood leaves the glomerulus, it will travel to a specialized series of capillaries called the peritubular capillaries and the vasa recta. These are part of the renal nephron, the functional unit of the kidney. The peritubular capillaries will wrap around the collecting tubules of the nephron, allowing efficient movement of ions between the blood and then the fluid in the nephron. From each set of peritubular capillaries, blood will flow out of the interlobular veins. From there, the blood will flow out a series of veins that are the direct reverse of the arteries, with the exception of there are no segmental veins. So the names are identical, other than instead of the word artery, you have the word vein. And then the blood will finally leave the kidney through the renal vein. First, you start off with the renal artery here. That will further branch into smaller vessels, 5 segments or segmental arteries here. That will further branch into various lobes of the kidney, so lobar arteries here. In there, the vessels will go in between individual lobes, so they're going to be interlobar arteries, such as right here, between here and here, so they're in between. And that you have arcuate arteries, that actually arc around pyramids, such as right here, they'll arc around. They have interlobular arteries. This is here. These will lead to the afferent arterioles. It's here is where the blood will enter the glomerulus. That's the main functional, or the main filtering unit of the nephron, which we'll talk about in more detail here in a few minutes. So after blood gets filtered there, they leave the glomerulus through the efferent arterioles, travel on to peritubular capillaries, interlobular veins, arcuate veins, interlobar veins, lobar veins, and then the renal artery. Alright, now we'll talk about the nephron, the main functional unit of the kidney. And each kidney has approximately 1 million nephrons. Nephron can be divided into two distinct parts. The renal corpuscle, which is the filter part of the unit, then the renal tubule, where reabsorption and secretion take place. We'll talk about the renal corpuscle first. Blood will enter the renal corpuscle through the glomerulus, which is really just a tangled mass of capillaries, very permeable capillaries. Now, surrounding the glomerulus is called the glomerular capsule, or called the Bowman's capsule. And its function is to basically catch whatever gets filtered by the glomerulus. And the layers of the Bowman's capsule are similar to the layers of a serous membrane. The inner layer of the capsule, the visceral layer, will surround the glomerular capillaries, and is made up of very specialized squamous epithelial cells called podocytes. And these make for a very efficient filter. The outer layer, the parietal layer of the capsule, is simple squamous epithelium. It will complete the filter. So what you have is blood flowing into the glomerulus, and everything but blood cells and a few of the larger molecules like proteins are pushed through the capillaries across the filter and into the capsule. So blood cells are going to be too large, they don't get filtered. Some of the larger molecules like proteins aren't going to be filtered because they're too big, but everything else gets filtrated and caught by the Bowman's capsule. So at this point, the material that gets filtered is now called filtrate. Now, if blood or a protein gets into the urine, it indicates a filtration problem within the kidneys. There are some things that should not be in your urine. So by knowing what should and should not be there is a good diagnostic tool to use to see what is wrong with the patient. Okay, so we're going to zoom in on this one area here. And all of the stuff that's going on is one nephron. Each kidney has 1 million of these structures inside it. This is where the filtering and the reabsorption gets done. So the key to looking at something like this is to follow the arrows. So the actual renal corpuscle actually has two parts, the Bowman's capsule and the glomerulus. This tangled mass here of capillaries, that is the glomerulus. So you have blood flowing into the glomerulus through the afferent arteriole. It is arriving at that structure. So blood will get squeezed through here. If it's filtered, it'll be caught by this structure, the Bowman's capsule. Looks kind of like a catcher's mitt. If things are too large, like most blood cells, larger proteins, they are not filtered and they continue on through the efferent arteriole, the vessel that leaves the structure. And from there, it will go on to the peritubular capillaries and eventually back to the renal vein. Now, stuff that does get filtered will stay in the renal tubule, and we'll talk about these other structures here in a few minutes, and we'll come back to this image. Alright, the rest of this nephron is a series of tubes called the renal tubules. Now, the filtrate that is formed from the glomerulus travel from the glomerular capsule into the first part of the renal tubule, called the proximal convoluted tubule. And it's called that because it's in proximity or close by the glomerulus. That's why it's the proximal tubule. And convoluted because it gets very windy and very twisty. Now, the wall of the proximal tubule is made up of cuboidal epithelium and is covered with microvilli. And from the proximal tubule, the filtrate will flow into the nephron loop, or what's more commonly called the loop of Henle. Now, this loop will have two parts: a part that goes down, the descending limb, and a part that goes back up, the ascending limb. All of that together is the loop of Henle. After the loop of Henle, the filtrate will go into the distal convoluted tubule. It's called distal because it's further away from the glomerulus. And the wall of the distal tubule is similar to that of the ascending branch of the nephron loop. Now, from the distal tubule, the filtrate will go into one of several collecting ducts, and this area is made up of cuboidal epithelium. The collecting ducts will lead into minor calyces. They merge together to form major calyces, which will lead into the renal pelvis, and then into the ureter. So at this point, anything that's inside the collecting ducts will end up in your urine, because it cannot be reabsorbed beyond that point. So any material that's in the collecting ducts will eventually be urinated out. All right, so going back to this image we saw a second ago. So filtrate gets caught here in the Bowman's capsule. The first part is the proximal convoluted tubule because it's close by to this structure. From there enters the loop of Henle, the part going down, descending limb, and the part going back up, ascending limb, then into the distal convoluted tubule here, and into the collecting ducts. So whatever is in here at this point will be urinated out. Okay, this image has more detail on the functional renal unit, the nephron. This includes what we just talked about, the glomerular filtration, the first part of making urine. But at this point, we talked about this first step, where blood from the renal artery is filtered into the glomerulus. The filtered product will have water and salts and nutrients, and then waste products called the glomerular filtrate. Alright, the blood vessels are in close proximity to the nephrons because substances will move between the tubules and the bloodstream. As we mentioned before, blood will approach the nephron through the afferent arteriole, so blood will flow from the afferent arteriole into the glomerulus. The blood flows out of the glomerulus through the efferent arteriole and into a network of peritubular capillaries and then a structure called the vasa recta. Now these surrounding blood vessels allow for reabsorption and secretion, and blood will leave the nephron through the cortical radiate veins. All right, now we'll talk about a clinical application, trauma, ischemia, and kidney damage. The kidney is going to be very well vascularized, and each nephron is surrounded by a network of blood vessels. Now the flow of blood is controlled by the afferent arteriole. When blood flow decreases for a period of time, oxygen delivery to the nephron will go down, and then you get ischemia as a result. Now blood flow can be decreased by any number of reasons due to hormonal mechanisms that cause prolonged vasoconstriction or even severe blood loss. If the situation continues for too long, the tissues can become ischemic and then eventually die, which will lead to kidney failure. And this may be temporary or it may be permanent. All right, now we'll go into more detail about the actual formation of urine. Now the kidney controls fluid and electrolyte balance by controlling the urine volume and its composition. In order to form urine, the nephron must go through three processes. We've talked about these, or we mentioned these before. Glomerular filtration, tubular reabsorption, and tubular secretion. We've already talked about this first step, where you get material filtered in the glomerulus. These next two steps are what people always get confused on and always get backwards, because the names give you the impression that the opposite is what's happening. And we'll go over why that is when we get to them in more detail. Our first one, filtration. During glomerular filtration, like we just talked about, fluid and molecules will pass through the glomerular capillaries into the capsule, and they flow across a filter that's composed of the walls of the capillaries and the podocytes of the glomerular capsule. Whatever is caught, whatever is filtered, this filtrate will flow into the renal tubule. And beyond that point, the chemistry is controlled by reabsorption and secretion. The filtration will move fluid and chemicals into the nephron from the blood, and glomerular filtrate is chemically similar to the blood. All right, now we get into reabsorption and secretion. Now urine is chemically different from plasma because reabsorption and secretion control the concentration of the chemicals and then the overall volume of urine. So substances that are reabsorbed pass from the renal tubule back into the peritubular capillaries and return to the blood. So tubular reabsorption is material moving from the renal tubule into the blood capillaries. It's being reabsorbed from the renal tubule, not into the tubule. That's where people get confused. Tubular reabsorption is reabsorbing material from the tubule. And substances that are secreted will pass from the blood capillaries, the peritubular capillaries, and enter the renal tubule, and eventually leave as urine. So tubular secretion is material being secreted into the renal tubule. Not secreted by the tubule, but secreted into the tubule. Now some substances, like glucose, are completely reabsorbed, while substances like metabolic waste products, urea, creatinine, are almost completely secreted as urine. This goes back to what I mentioned earlier. Some things should not be in urine. Some things should always be in urine. Glucose should never be in your urine. If you do have glucose in urine, that's an indication of something is going on, either with the pancreas or with the kidneys, or perhaps both. Alright, we're focusing just on one glomerulus here. It's a tangled mass of very permeable capillaries. The Bowman's capsule that surrounds it. It's ready to catch the filtrate. You have blood going in the afferent arteriole. Whatever gets caught goes down to the proximal convoluted tubule. Whatever doesn't get filtered out will remain in the blood vessels and will leave the structure through the efferent arteriole. So that takes care of part A in this image, the filtration. That goes on to reabsorption. Material is reabsorbed from the proximal convoluted tubule into the blood capillaries. And most of the material that gets filtered will get reabsorbed into the blood capillaries. And tubular secretion, material being secreted into the tubule from the blood capillaries. At this point, it will be urinated out as urine. Alright, here's a table that has some basic kidney fluid chemistry, various substances, comparing that to blood plasma and glomerular filtrate and then urine. And all these are in concentrations of milligram per 100 milliliter. So, for example, protein, pretty high number in plasma. There should be none in filtrate because they're just too big to be filtered. So they don't end up in the filtrate. That's why the answer is 0 here. And there should be none in your urine. If there are proteins in your urine, then something is going on somewhere. Glucose, the same thing. Same thing for sodium. There should be higher amounts of potassium in urine than there would be in your blood plasma. Much more concentration of urea in your urine. Much more here as compared to the filtrate or in your blood. Same thing with creatinine. Much higher concentration in your urine, or it should be, compared to that of filtrate or blood plasma. Right now I'll talk about the control of filtration. Filtration is controlled by several factors. First one is filter size. This will determine what gets through the filter. Podocytes and capillary walls of the renal corpuscle create a filter with a very fixed set of openings. Plasma and many other substances that are dissolved in blood plasma pass through the filter with no problem, but blood cells, platelets, large molecules can't get into a healthy kidney. They're just too big. They don't fit through the holes of the filter. Another factor that controls filtration is pressure. There's a higher pressure on one side of the filter that allows chemicals to be pushed through the filter more quickly. And that's because the size of the efferent arteriole is smaller than that of the afferent arteriole. And a good analogy to think about this is turning on a garden hose and then putting your thumb over the edge of the hose. When you do that, the water comes out faster. This is called the Bernoulli effect in physics. You have fluid moving through a more narrow space, so its velocity will increase. Well, it's the same thing that goes on in your nephrons. Because the efferent arteriole is narrower, or the diameter is smaller, it will flow faster. So the faster it goes through, the more it can be filtered at a faster rate. So a higher blood pressure in the glomerular capillaries will increase the filtration, and of course the opposite of that will be true. The lower blood pressure will decrease filtration. Here's an example of filter selectivity. Blood plasma up here with the various components. We have urea, red blood cells, creatinine, sodium. They have the various filters here. As the pressure will push this material forward, some things get through, some things don't get through because they're just too big. Red blood cells like this are too big for these filters. They just don't make it through. But smaller components, like sodium, like creatinine, like urea, do get through. Now, changes in blood pressure can change the filtration rate. Now, minor changes in systolic blood pressure do not change the glomerular pressure because it's protected by a mechanism called autoregulation. And how this works is, as the systemic blood pressure increases, the afferent arterioles leading into the glomerulus will constrict, decreasing the amount of blood getting into the glomerulus. And autoregulation can be overridden. Since the kidneys will regulate fluid volume, the kidney can work with the cardiovascular system to regulate blood pressure. Now, the glomerular filtration can decrease to conserve fluid when blood pressure falls, or increase filtration when blood pressure goes up. It is the sympathetic nervous system that can control urine production through the adrenal medulla. And whenever you're in an emergency situation that the sympathetic nervous system helps to control your response to, some things that aren't necessary in that kind of situation are basically shut down. Digestion gets shut down. Kidney function gets shut down. So that's what that last bullet point is a reference to. All right, now we'll talk about diabetic nephropathy. Diabetes mellitus, or DM, is characterized by high glucose levels from inadequate or lack of insulin. This is the diabetes that you think of when you hear the term diabetes. It's officially diabetes mellitus. The high glucose levels can really wreak havoc on the osmotic pressure, or the osmotic balance of the blood. The kidneys will work hard to remove any excess glucose, but the urine output is high. Over time, the kidney is going to be damaged, diabetic nephropathy, beginning with the thickening of the filter surface of the glomerular capsule, which will eventually lead to the breakdown of kidney tissue, which will eventually destroy the filtering ability. So substances that would normally not pass through, like blood and protein, begin to appear in urine when they shouldn't. Now the kidney function will continue to deteriorate. Diabetics can prevent the onset of this type of kidney damage by controlling their blood sugar levels, also by preventing high blood pressure and reducing the blood cholesterol levels. It's the leading cause of kidney disease in America. Another condition, PKD, Polycystic kidney disease. PKD is a genetic disorder in which a large cyst will form within the kidneys. A more common form is the adult onset disorder. It's characterized by a decreasing kidney function, but the nephrons are normal, and they're just displaced by the cyst. And there's no cure for this condition other than getting a kidney transplant. There's a comparison of a damaged and a healthy kidney. Now, this is how it should look around this size. We can tell a much different story with this image here. Nowhere near what a normal kidney should look like internally. Having all these various holes here, various growths over here, and here and here. So this is a very damaged kidney on the left. Alright, we'll talk about the control of tubular reabsorption and secretion. Now, tubular reabsorption and secretion will control the chemistry and then the volume of urine. So substances that are reabsorbed move from the tubule back into the blood via the peritubular capillaries, and then they stay in the body. And substances that are secreted stay in the tubule and eventually leave the body via the urine. Anything that affects reabsorption and secretion will affect urine chemistry. Alright, the first thing that affects tubular reabsorption and secretion is the tubule permeability. Each section of the tubule can reabsorb and secrete different substances. And molecules will move across membranes through several different methods, including diffusion and including active transport. Now, the differences in the tubular permeability result in very dramatic differences in what molecules are reabsorbed or secreted and in what part of the tubule. Here's a good table on individual tubule functions. On this side, we have the actual portion of the tubule, and what can be reabsorbed or secreted. See the proximal tubule. Now, a very long list. Most of the material that gets filtered in the glomerulus, about 70% of that will get reabsorbed in the proximal convoluted tubule. See the descending limb is permeable to water and not much else. The ascending loop, sodium will pump out sodium and potassium and chloride ions and then urea. The distal tubule and collecting ducts, those are under hormonal control also. So different parts of the tubule are able to reabsorb or secrete different material at different rates. All right, now we'll talk about another clinical application. We'll talk about kidney stones. Now, kidney stones result when substances in the urine will crystallize in the renal tubule, often because the concentration of the molecule is much higher than it normally should be. Now, the cause of stones is frequently a mystery. Now, stones can be made up of a variety of different material. They can be calcium or uric acid, or can be caused by kidney infections. Now, some people are just more susceptible to developing kidney stones than others. Some stones will pass unnoticed, while others that are quite large or that are irregularly shaped may lodge within a tubule, which will obstruct the flow of the fluid and irritating nearby tissues. So some of these can be incredibly painful. Now, symptoms of kidney stones: blood in the urine and severe flank pain. Kidney stones usually present as lower back pain at first because the kidneys are retroperitoneal. Stones may move on their own, or they may be treated by increasing your fluid intake, or lithotripsy, which is sending shock waves to break up the stone. Or if none of those work, then surgery to actually remove the stone that's causing the obstruction. Now, patients are asked to filter their urine to look for any possible stones that they pass on their own, because some can be as small as grains of sand. Alright, going back to the control of tubular reabsorption and secretion. There's a special type of circulation around the nephron loop, or the loop infinity, and this is called the counter-current circulation. In here we have ions that move across cell membranes that go from an area of high concentration to areas of low concentration. Now, water and ions tend to move in opposite directions, making it impossible to move both without the special environment around the nephron loop. And it's called countercurrent because you have material moving in two separate directions. You have material moving down the descending limb of the loop and then moving back up again in the ascending limb. That's a countercurrent mechanism. Now, this concentration gradient, with low ion concentration at the beginning of the descending loop and high concentration at the tip of the loop. So as you get further down the descending limb, you become more and more concentrated. And adding to this, the differences in impermeability between a descending limb and the ascending limb will affect water and also ions. So what you have here is the filtrate flowing into the descending loop, reabsorbing water and increasing the concentration of the ions. You get more and more concentrated as you get toward the bend of that curve, or bend of that loop. As the filtrate enters the ascending limb, fluid is very concentrated due to the water loss. And the membrane is permeable to only ions, and ions are pumped out across the membrane through active transport. Okay, so here's what's going on. You have the fluid going down the descending limb, material moving down here, then moving up here. So that's a countercurrent system. So at this point, here at the bottom of the nephron loop, very highly concentrated material. And by the time you get to the top of here, you'll have a very weakly concentrated solute. And weaker than what you started off with here. So what the countercurrent system actually is, in a very general way, is what gets pumped out on this side of the loop affects this side of the loop. So what gets pumped out and reabsorbed here affects this side. It's also called the countercurrent multiplier. Each side of the nephron loop is affecting the other. So what goes on here has an impact on this side. What goes on this side has an effect on this side, and vice versa. Alright, now we'll talk about an applied science, electrolyte and acid balance. The kidney will maintain electrolyte balance by selectively excreting or reabsorbing electrolytes within the tubular system. The relationship between hydrogen ions and bicarbonate ions will determine the blood pH, whether it be too acidic or too alkaline. This is called the acid-base relationship. If too much acid is present, hydrogen ions will be excreted to a higher level in the urine, and more bicarbonate ions will be reabsorbed to balance that out. The respiratory system will also play a role by blowing off more carbon dioxide, which is an acid. This also has a role with maintaining your pH balance. The third factor that will affect reabsorption and secretion are several hormones that will help regulate blood pressure. These include ADH, antidiuretic hormone, aldosterone, atrial natriuretic peptide, and then renin, angiotensin, and aldosterone. First, we'll talk about hormonal control. ADH, antidiuretic hormone, is a hormone that's made in the hypothalamus of the brain and secreted from the posterior lobe of the pituitary gland when blood pressure decreases or when there's an ionic concentration that increases. Now, ADH will increase the permeability of the distal tubules and of the collecting duct. This will help you to conserve water. A diuretic is a medication that makes you urinate more. So antidiuretic will help you conserve water, make you urinate less. So when more water gets reabsorbed, this will increase blood volume, which will increase blood pressure, and therefore diluting the ionic concentration. The overall point of ADH is to make less urine. Now things like alcohol or caffeine will inhibit ADH, which is why you urinate more whenever you drink caffeine or whenever you drink alcohol. The aldosterone is an adrenocorticosteroid that's secreted by the adrenal cortex. It's secreted when the plasma sodium decreases or the plasma potassium increases. And its function is to increase the reabsorption of sodium ions and also to increase the secretion of potassium ions. And by doing so, it will increase serum sodium levels and decrease serum potassium levels. It's done so by the distal tubules and the ascending limb of the nephron loop. So the whole point of aldosterone is to hold on to and retain sodium ions and get rid of potassium ions. As sodium is reabsorbed, water is also reabsorbed. It goes along with that, and this will decrease urine volume. So whatever you are absorbing, you don't urinate out. Another hormone, ANP, atrial natriuretic peptide. This is secreted by the atria of the heart when blood volume increases. Now, ANP will decrease sodium reabsorption and thus increase urination. Whenever there's too much blood volume, that's going to make the heart work more. So the heart atria will secrete this hormone to tell the kidneys to produce more urine to reduce the blood volume, which will lower blood pressure. The next one, the renin-angiotensin-aldosterone system, is a series of chemical reactions that help to regulate blood pressure. Okay, whenever there's a decrease in blood flow to the kidney, this causes a special group of cells near the glomerulus, called the juxtaglomerular apparatus, to secrete renin into the bloodstream. Now the liver will secrete a chemical called angiotensinogen. The renin will convert that into angiotensin 1. Now another enzyme that's made by the lungs, called ACE, angiotensin converting enzyme, will convert the angiotensin 1 into angiotensin 2. This will increase thirst, which will increase ADH secretion, which will increase aldosterone secretion, which will cause vasoconstriction. And the whole point of all of this is to increase blood pressure by increasing fluid volume. All right, now we'll talk about the urinary bladder and the urination reflex. The glomerular filtrate will flow out of the collecting duct, which will go into the minor calyces, and then into the major calyces, and then into the renal pelvis. Now once the glomerular filtrate leaves the collecting ducts, its concentration can't be changed, and it's going to be urine. Nothing can be reabsorbed or added or taken away from that. The urine will collect in the renal pelvis and will flow down the ureters into the urinary bladder, where it is stored. That takes us to the urinary bladder. The bladder is a small, hollow organ that's posterior to the pubic symphysis and behind the peritoneum. It is lined with transitional epithelium. It's the only epithelium that is stretchy enough to expand as the bladder fills, and the only place you'll find this type of epithelium is in the urinary tract, so within the bladder, within the urethra, within the ureters. And the ability to stretch is enhanced by a series of pleats called rugae. It's like we had rugae in the stomach that allow it to expand and then recoil back to its normal size. It's the same setup here. Now the bladder has a muscular wall that's consisting of several layers of circular and longitudinal smooth muscle, and it's covered by connective tissue and parietal peritoneum. All right, here we go. We have the kidneys here on top, with each one with their ureter leading to the bladder. Of course, that will lead on to the urethra. They'll be urinated out. All right, the urination reflex. As urine will accumulate in the bladder will fill and stretch, and this stretching triggers the urinary reflex and the need to void and to empty the bladder. Now, urination has been thought to be a spinal reflex, but there's some new research that indicates it's controlled by the brain. Now, when your bladder gets full, signals are sent from the bladder to the spinal cord to the pons, which is the part of the brainstem. The pons sends parasympathetic signals down the spinal cord, causing constriction of the muscular walls of the bladder, and therefore the bladder empties. All right, that leads you to urination. Urine leaves the bladder via the urethra, which is a thin muscular tube lined with several different types of epithelium. throughout its length. Now, part of your brain can inhibit urination by controlling the internal urethral sphincter, which is a valve at the junction of the bladder and urethra, and also with the external urethral sphincter, a valve that is a part of the muscles of the pelvic floor. Now, sympathetic stimulation of these sphincters prevents urine from leaving the body. Now, although you have little control over bladder contraction, you do have good control over the sphincters starting from age 2, or a little bit later than that in young boys. All right, now we'll talk about common disorders of the urinary system. Overuse or abuse of drugs can severely affect renal function because the kidney will excrete most medications after the liver breaks them down. The analgesic nephropathy, this is caused by long-term use of pain relievers, particularly the NSAIDs, the non-steroidal anti-inflammatory drugs, like ibuprofen, like naproxen, and particularly if these are combined with caffeine or codeine or acetaminophen. Now, prolonged use of these over-the-counter drugs can lead to chronic kidney damage, which can lead to kidney failure. The CRF, chronic renal failure, is an ongoing progressive disease of the kidney. The progression may be controlled by treating the underlying cause of the damage or by controlling blood pressure and cholesterol. The CRF can lead to end-stage renal disease, or ESRD, which is the final stage of renal failure. And the only treatment for ESRD is dialysis or getting a new kidney. The diabetes insipidus, DI, is an endocrine disorder characterized by having too little ADH, or an insensitivity of the kidney to ADH. So even though the word diabetes is included in the title of the condition, it's not really related to blood sugar or pancreas. The result of having DI is producing very large amounts of urine. You're urinating all the time, and every time you go, you're urinating out a large volume. So this leads to dehydration, which will lead to rising sodium levels in the body as your body tries to counteract all that loss of water. So it's trying to conserve as much as it can. And this isn't treated, can be fatal. And the opposite of this condition is called water intoxication, in which patients have an uncontrollable thirst and drink so much water they create dangerously low sodium levels because of the volume of the water that is diluting it. And this can lead to brain damage or even death. So as important as water is to the body, having too much of it is still very dangerous. The glomerulonephritis, this is an inflammation of the glomerulus. Glomerulosclerosis is the scarring of the actual glomerulus. And both of these can cause damage to the delicate filter apparatus in this unit. Once that filter gets damaged, blood cells and blood proteins are now able to enter the filtrate and eventually appear in the urine. Now, removal of waste products is decreased, and electrolyte balance is usually very abnormal due to the change in the urine chemistry. Again, some things should be in urine, some things should not be in urine. When you mess with that composition, you can mess with your overall electrolyte chemistry. There are many causes to the condition, including bacterial infections, diabetic nephropathy, systemic lupus, and genetic disorders, including Alport syndrome or Goodpasture syndrome. Hemolytic uremic syndrome. This is a disorder caused by an infection of the bacteria E. coli, or undercooked meat. Now, the bacteria will infect the digestive tract and will release toxins that will destroy red blood cells. The damaged red blood cells get lodged in the blood vessels of the kidney, blocking them and preventing blood flow to the nephron. So without treatment, there can be permanent kidney damage that may result. Now, a blood transfusion of the blood or the wrong blood type can also lead to the same effect. We'll talk about another clinical application, UTIs, urinary tract infections. These are caused by the movement of fecal bacteria into the urinary tract. The symptoms of this could include frequent and painful urination, bloody or cloudy urine with an unusual odor, and having low abdominal or pelvic pain caused by a bladder spasm. Now, treatment should begin promptly to avoid any further kidney damage and also to prevent the infection from traveling from the bladder to the kidney. Now, UTIs are much more common in women because the urethra is much shorter compared to males. The length of the urethra in males is about 5 times as long as it is in females. Drinking plenty of water can help prevent these kinds of infections. And then once diagnosed, they are treated with antibiotics and increased fluid intake. All right, we'll finish up this video in this chapter with some points of interest. The urinary system consists of paired kidneys and paired ureters, which carry urine to the single urinary bladder. The urethra will transport urine from the bladder to the outside of the body. The function of the urinary system is to control the fluid and electrolyte balance and the elimination of nitrogen-containing waste. The kidney is a bean-shaped organ that's covered within a capsule. There's an indentation called the renal hilum and an inferior cavity known as the renal sinus. The kidney can be divided into three different regions: the cortex, which is the outermost region, the middle layer, the renal medulla, or innermost layer, the renal pelvis. The pelvis is a funnel-shaped structure that is divided into basically large pipes, which are the major calyces. Each major calyces is divided into several minor calyces, and the renal pelvis is what will empty into the ureter. The kidney is very well vascularized. Blood is supplied to each kidney by a renal artery, and blood vessels will split into smaller and smaller branches of this artery until you end up with many or millions of tiny arterioles, the afferent arterioles. The afferent arterioles will supply millions of nephrons, which are the main functional unit of the kidneys, with blood. Blood will leave the kidney through a series of veins and ultimately return to the circulation via the renal vein. The nephron is a functional unit of the kidney. There are millions of nephrons at each kidney. The nephron is divided into two parts: the renal corpuscle, which consists of the glomerulus, and also the glomerular capsule, or the Bowman's capsule. And it is there to filter blood and produce the glomerular filtrate. The renal tubule, consisting of the proximal tubule, the loop of Henle, or the nephron loop, and the distal tubule, and the collecting ducts. These all control the concentration and volume of the urine by reabsorbing and secreting water and electrolytes and other molecules. The walls of the nephron are made up of epithelium, and the type of epithelium will change depending on the specific function of that part of the nephron. Urine, formed by a combination of three different processes: glomerular filtration, tubular reabsorption, and then tubular secretion. The selectivity of the glomerular filter is determined by the size of the openings within the filter and the difference between the blood pressure of the glomerulus and then the pressure in the glomerular capsule. The size of the filter does not change unless the glomerulus is damaged somehow. The proteins, for example, cannot pass through the filter. However, the filtration rate will change if the pressure in the glomerulus changes. Most of the time, autoregulation will control the diameter of the afferent arteriole, keeping the glomerular pressure and the glomerular filtration rate constant. But sympathetic stimulation can regulate, and in this case decrease, the filtration and urine output due to the constriction of the afferent arterioles. The less blood goes into the glomerulus, the less blood can be filtered, which means less filtrate, which means less urine produced. Tubular reabsorption and secretion is controlled by differences in tubular permeability. The proximal tubule is the most versatile in reabsorbing dozens of different molecules. The nephron loop is a part of the elaborate countercurrent mechanism, or the countercurrent multiplier, with a descending loop being much more permeable to water, and the ascending loop being much more permeable to ions. The distal tubule and the collecting ducts will reabsorb water, and the permeability of the renal tubule can be regulated by a number of hormones that help to control blood pressure. These hormones, including aldosterone, ADH, ANP, among others, regulate blood pressure by regulating the urine volume and the ion secretion. Now, changes in urine volume change total body fluid volume and thereby change blood pressure. The urinary bladder is a collecting and storage structure for urine and located within the pelvic cavity. It has a muscular wall. The contractions of this muscle result in the voiding, or the urination, thereby emptying the bladder. And urination is a reflex that is controlled by the parasympathetic neurons within a part of the brainstem called the pons. Signals from a full bladder reach the spinal cord and then onto the pons. The sympathetic neurons control two valves, the internal and external urethral sphincters, both of which will allow significant conscious control of the urination reflex. So you can't control the contraction of the bladder, but you can control if the sphincters are open or closed. That brings us to the end of this chapter on the urinary system. We will continue our video course on anatomy and physiology with our next chapter on the reproductive system.